While we're waiting, let me just say to the audience that I try to gear my talk towards therapists, towards parents of patients, and towards patients. So um, if it's a little bit too general for some and too specific for others, I'm trying to get as much as I can to all that are involved. The other thing is because of the volume of information I'm trying to get across, the slides are not busy, but they're full of information. So be aware the slides are available on the website following the presentation. So if you feel like you've missed something, you really haven't, because it's always going to be there to look back on. I'm going to try, given the time that we have, to present the information I think needs to be presented in this forum, but there's also other information on the slides that will help therapists, parents, and patients understand what our goals are for this talk. So my portion of this will be to try to present therapeutic exercise interventions to assist in bridging that gap from the hospital to the community for postoperative CP patients. Next slide, please. My hopes are to present these tables to reference several surgical procedures that are with some significant timelines. I'd like more so to highlight the precautions for our therapists when working with these patients and areas of focus postoperatively. Suggest exercise strategies depending on the restrictions given by the doctors and the expected endpoints for the particular patients, and to spotlight the importance of team communication. Next slide, please. This graph, this chart will go to pieces at a time, so it's all here in one place, but we will address it in the upcoming slides. Next slide, please. These two procedures I put together, the pelvic osteotomy and the foot reconstruction, in that they typically have a long period of non-weight bearing on the limb that's being operated on after the procedure. It could be up to from 3 to 8 weeks. The treatment of those patients who've had hip surgery doesn't wait until they're allowed to weight bear, because you still have work you can do on the upper extremities if they do use their arms for weight bearing, for transfers, for assistive device use. And you can still, even though the hips have been worked on, you can still do some isometric work in strengthening the quads and the hamstrings if their patient may go into a stander. With these patients also, you want to do your best to maintain their foot position and knee position so you don't have secondary contractures forming after having their hip surgeries. Next slide, please. With the foot osteotomies, and if you hit again, you'll have my picture come up. With the foot osteotomies, they sometimes are said to be allowed to be toe touch weight bearing if there's significant internal fixation and the walking cast is applied. But I've heard from Dr. Selber that even with these patients, he prefers to maybe keep them non-weight bearing for the first 2 to 3 weeks. Because of the issues with edema, you want to be sure to elevate the lower extremities when you're not working or in between activities, so you don't have a lot of swelling compromising your healing and comfort. The casts that are placed after the foot osteotomies may stay up to maybe 6 to 8 weeks. If there's a plan to have some sort of a brace made for the patient, the cast is removed at about 4 weeks. They're molded for the brace. The cast is put back on, so they have enough time for the brace to be fabricated. So in that end period, when they're out of the cast, the braces are prepared and ready for use. Next slide, please. These 3 procedures are the osteotomies of the femur and of the tibia. The proximal femoral osteotomy, you still want to get them walking immediately. You don't immobilize, and you want to go hopefully from walker to crutches within about 4 to 6 weeks for the GMFCS1s. The 2s may take a bit longer, maybe up till 6 weeks, and depending on the size of the patient and how long their limbs are, given that if they're more weighty, if they have more weight to them, more girth, they're at risk for that weight going out of control and having some issues with forcing them into positions you don't want those legs to go into too soon. So you may have a longer time before you progress them further on. For the distal osteotomies, again, you want them to be walking, probably with a walker. Long leg casts or knee braces, probably braces at this point. I don't think we use casts anymore. But you want to protect that distal part of the femur that's been cut, rotated, or repositioned, and then supported with some external metal. And when they do get that clearance to remove the bracing, you want to be sure to do it gradually. If it's bilateral, you may want to have one leg braced or in support while the other one is free, and vice versa. So you don't have them going from fully braced and weight bearing to no brace whatsoever and very tenuous on your legs. When you are doing these rehab for these patients, remember, all of these procedures are done for alignment issues, and with bad alignment come bad muscle activity. So when you're finally given the go ahead to get them active, get them moving, I would suggest that you're very strict in what you allow them to do and what you expect them to do. My patients know me, and we have fun, but we still have work to do. And given where these children come from with poor alignment, poor strategies, and now they've gone through a surgery to correct that alignment, it's incumbent on us as therapists to get them the best outcome. So even if it's a simple step up, step down, weight shifting, you really want to control that movement because they've gone through surgery to correct as much as they can orthopedically. Now as therapists, we have to go and do our part to not let's just put them into a walker and say, oh, let's walk across the floor. We really have to do those pre-gait activities, weight shifting, weight acceptance, body movement, so you get the best you can out of these procedures. Next slide, please. Just to show some of the, like on the right, I don't have my pointer unfortunately, but on the right you have the femoral proximal osteotomies. On the top, so on the left you have the femoral osteotomies proximally. On the left you have the top with a distal femur, and on the bottom you have the tibial osteotomy. So I used to be very concerned when my patients were so uncomfortable, and I know the bone was cut, the bone was repositioned and then supported, but seeing the amount of hardware that's in there and knowing that our physicians have been in there, know what the bone stock is like, and when they say we're ready to go full weight bearing, do whatever you need, you can do, I tend to put my faith and my trust in our orthopedists. Next slide, please. This is one of my favorite procedures because you can do anything you want with this patient. There are two scenarios with this particular procedure. It's called the femoral growth plate episiodesis. And if you look at my picture or my depiction on the right of the screen, in green you have the growth plate stapled on both sides. So the way this would work, if you have a longer leg or short leg more so, and you want to have the shorter leg catch up to this longer leg, the growth plate is stapled, so it retards or slows down the growth of that long bone. And the other leg, the one that was shortened, is now allowed to weight bear to start to increase the growth so it can catch up. It may not catch up fully, but it's a better chance of getting those bones to be more symmetrical and get a better outcome with the gait training you do with the patient. In red, you'll see a different possible use of this particular procedure. And I think hopefully Dr. Hyman and or Selva will talk about this also at some point with our later discussion. If the bone is curved, meaning the place where the arrow is on the inside of that curve is shorter and the outside is longer, if you staple in red the outside or one single side of that growth plate, the other side can tend to lengthen and improve that alignment. You're not going from here to here, but you do get some improvement in the shape of that bone, and therefore in the way the muscles that are attached to either end of that bone can function for this patient. When you're doing surgery on these leg length discrepancy issues, consider elevating the shorter leg. So you've had a leg that's been shorter, so you know there might be an issue with the ankle with plantar flexing to reach the floor to balance off the pelvis. So if you're doing squats, let's say, you can still do a normal squat. Just think of elevating that or supporting that shortened leg. So now the knees are aligned, the hips are aligned, and you can go through a squat movement and get those muscles of the patient weight bearing through that bone to encourage more movement. You want to go through knee flexion, extension, range of motion. The uncomfortable leg in this procedure is the one that was normal, the one that was longer. So even though you're really working with a shortened, affected leg, after the surgery, that better leg, the good leg, is the one that had the staples put in, and the one that will be at risk for losing some range if you allow them to do that. There's no damage to the bone, there's no damage to the soft tissue, do your best to encourage that patient to get full range of motion as soon as possible, because you're going from weight shifting to weighted activity to plyometrics. You want as much force and work through that bone to encourage growth as you can as this bone heals. And as you get that increase in length and symmetry, hopefully over time. Next slide, please. This is a list of our some of our soft tissue procedures. The psoas lengthening over the brim of the pelvis is, if you picture your child with the excessive lordosis, that iliopsoas gets shortened. So the idea to improve alignment is to lengthen that iliopsoas, but it's incumbent on us as therapists to position them in prone after the surgery to try and get as much stretching and repositioning of that as we can. If we do the surgery and they go back to fetal positioning or sitting all day, we really have not benefited this patient. The next surgery is the proximal rectus femoris release or lengthening. Similar issue with dealing with the position of the hip. Weight bearing immediately after the surgery. They may need crutches. We do not immobilize. We try to get them to be as active as possible. And again, you don't want to lose any of that range. The third, and I put a little picture there of a patient in crouch gait, the patella tendon shortening procedure. It's what's called the salvage procedure for crouch gait. So we're not going from a patient who's crouched to a patient who's walking fully normally gait motion and running through the park. But if you don't do something for this patient, in very short order, they may be unable to ambulate safely and maybe in a wheelchair over their early adult life. So this procedure requires that you shorten the patellar tendon, but then after the surgery, you give that tendon time to scar down and remain short. So they're in an immobilizer right from the OR. You're not going to be passively flexing this patient until you're given orders to start range of motion, which could be as much as 6 weeks after the surgery. And when you are given the okay to start doing ranging, you only have the patient actively flex. You're not cranking away on this patient. You're not forcing any more flexion, because if you are overzealous, you end up with a patient in crouch with nowhere else to go to get that crouch addressed. So you want to be very careful to maintain that immobilization that the doctor put in place until you get the go-ahead to start flexing. And at that point, you only want to have the patient do the active flexion, not you forcing some passive range of motion onto the patient. And we're reminded by Dr. Selber and his information he's learned through gait analysis that we only need about 60 to 80 degrees of knee flexion to do our transfers, do our walking, negotiate stairs. So you're not going to 120 degrees. You're fine if you get to 60, maybe 80 degrees of flexion. Next slide, please. Another procedure, and Dr. Selber talked about it earlier, the SemiT Transfer. So I'm not going to go too much into this slide, but the information is there. One of the things we do suggest, or we do caution you on, if you think of how runners typically stretch a hamstring, they have one leg out straight and they force their body forward to do that stretch. With this procedure, you really want that reattachment of the connection distally for that muscle to scar down and heal. So you want to have the patient, they can sit upright, they can maybe slightly flex forward, no active forward bending to do that stretch, because you're compromising that connection to that tendon that you've moved. And so we give them about maybe 6 weeks of immobility, and when the doctor says you can move forward, then you can move forward. The next procedure is a distal rectus femoris transfer to gracilis or fascia lata. This is a patient, when you see them walking, you may find them with a very stiff gait. So as soon as they try to flex the hip, rectus also straightens out the knee. In that case, we can shorten the rectus or change the attachment of the rectus distally, so it can still function to flex the hip, but not as much to extend the knee. You still have other knee extension muscles, which need to be strengthened now to have good support and control of knee extension. And you also want to work on knee flexion. So you are told by the physician that we should get up to 90 degrees in the first 7 days. It sounds like a lot, and it definitely is a lot. And of course, the doctors tell us also that this procedure is very painful. So you've got a painful procedure, and if an orthopedic surgeon tells you it's painful, you can probably guarantee it will be painful. and you have them saying you've got to get at least 60 degrees, if not 90 in the first week. Do not take your time with this patient. You really need to get on board and get the flexion you need, because that range of motion, that movement is very, very important. So early range, we'll deal with pain the way we are able to deal with pain, but don't let that stop you, not to torture a patient, but to get them the best outcome from this procedure by following the doctor's prescription. The next procedure is called the Splat Procedure, and I'm actually going to ask Ross to go to our next slide for a moment. On the left, you have a graphic of the procedure. The tendon goes medially normally. The tendon is split to go medial and lateral to align the foot in a better position. If you look at the upper right slide, on the left of those two, you see the poorly positioned foot with the internal eversion of the foot. And hopefully, if everything's done as it should be, you see how the split tendon is able to realign that foot. Ross, if you back up to the previous slide, please. Thank you. If you look to the bottom, we have, they're in some sort of cast immediately, and that cast stays on for about 7 weeks. Reason being that you reposition the tendon that pulls on that foot, but it's got to heal to the bone appropriately. And the other muscles that are also tending to pull in that direction need to be trained to not force it into that inverted position. So you are weight bearing, you are getting the patient to do whatever they can to position that foot in a plantar position with their casting in place, but you try to minimize any time that they're not in a good alignment. After the cast has been removed, which could be about maybe 4 or 5 weeks post surgery, they will be in a solid AFO. It could be a PLS or an AFO that's solid, or sometimes you see locked hinge AFOs, but you want to decrease or minimize that poor positioning. So no, well, I gave them a break at night because they really didn't want to walk, they had to go walk around the house, or no, mom says that they can have Saturdays and Sundays off because it's a weekend. You do what you need to educate this family and this patient that to get the best out of this procedure, they need to follow these restrictions. Next slide, please. Let's stick with this for a moment. On the bottom right, you have a depiction of some of the progression of the calf surgeries. At the far left, you have the surgery where they just address the fascia. And I really find it interesting the way the surgery goes, because the fascia is cut, and then you allow the patient's weight bearing to set that new position of the muscle. So I think of it as, if you think of a sausage that's been cooked and you slice the casing of that sausage, the sausage becomes a little bit more flexible because that support that's given by the casing is no longer patent and fully there. That fascia being addressed the way it is by the doctors, and I'm understanding that by the doctors saying that in the OR, they cut the fascia and they see if they get someplace close to a neutral plantar grade position of the ankle. That way, if you're looking for a child to go from plantar flex position to neutral standing, you can get that without compromising the muscle very much. As you go down the chain to the right, you're going more and more into muscle and then more and more into tendon, which again, depending on the patient choice, can be a very good thing for the patient or it could be extremely detrimental. Let's go to the next slide, please. Again, the same similar depiction of the procedures and where they occur. So for patients who need to, again, just get into a good weight-bearing position, zone 1 and sometimes zone 2 are used by our doctors. Next slide, please. For patients who are non-ambulatory, you might have your doctors do what's called TAL, tendon Achilles lengthening. That's to get good positioning for bracing, for sitting in the chair, for if they're, let's say, going to a stander, to get them into that stander with some external support. You don't do this and not have bracing. And it's typically for GMS-CS level 5s and possibly 4s. For those therapists who may or may not have had 1, 2, or 3 patients who they've had a similar procedure, which involves a tendon and some lengthening, true, they do look great early on because you went from having a kid who's up on their toes and really can't get down to a kid who's flat. But do keep in mind that that weak gastroc can only support them for so long. So if that tendon's compromised and then their weight bearing over time, those kids who are maybe standing for the first time in a plantar position early on can then sort of sink down into a crouch because they have no reserve. They have no increased muscle strengthening that gastroc and soleus, and they have the tendon that's been compromised, and then it sort of collapses into extreme dorsiflexion, and they end up standing in a crouch. Next slide, please. First and last thoughts on the information I've tried to present. In the hospital, we try to really schedule patients when they're most comfortable. And again, comfort is a relative term. It's hard to say how comfortable you can get a postoperative child who has to get up that same day. But we try to really reach out to the nurses in the hospital and let them know when we're coming, let the parents know when we're coming, let the patient know when we're coming, but also to get them to take part in their pain medication schedule. I've had patients and parents say to me, I really don't think I want the pain medication because I don't want to get hooked on any kind of narcotics. But again, that given the situation that they really need to be up postoperatively, if they're in pain, they're not going to function very well. They're not going to perform for you and get up. They're going to be really resistant to that activity. So we try to keep them on whatever pain schedule of medication they're put on by the doctors, because they know how much medication a child's body should be able to tolerate, and they make adjustments as they need to. The other thing that comes up in the hospital, and I'm sure even more so at home, I've had parents try to say to us that, oh, well, they're sleeping now, they're comfortable, let's leave them alone till they wake up. If you allow that pain medication to leave their system and then try to get that pain controlled, it's never a good situation. So when they leave us and they go to their homes or go to their secondary rehab facilities, they're given a pain medication regimen and schedule. I encourage you to have the parents and patients stick to that schedule for the first week or so they could actually get on an activity program. Once they're active and moving, the activity tends to get them a little bit more set and prepared for what comes next, and they do much better. But if you let that pain get out of control, especially that child who needs to get that range within the first week, you have a lot on your plate in addition to the surgery that's been done. And lastly, I saw one of the questions to Dr. Hyman and Selber asking about a patient in school who the therapist had no idea what was done, no idea what was the protocol for the patient. Communication is of the utmost. So as a therapist who works in a facility, I'm trying and hopefully to help the doctors and their nurses and all that are involved in their care figure out a better way to get the information we know is so valuable to the home, to the treating therapist, so there's no misunderstanding, there's no miscommunication, and there should be a back and forth, because once they leave us, they're in your hands, and we're trying to educate you as much as we can on things to look out for, things to not do that might hinder or impede their progress. But we need to hear about those things as soon as possible. So if you find that there's a drastic change in their function or what they look or how they present when you see them, there has to be a mechanism to get that information back to us and have the patient be seen as quickly as possible. So we do understand the need for that communication, and we are working to, as best as we can, get that communication in place so it's a two-way street. Next slide, please. One of the things I like to show is I really like using this equipment. BOSU, believe it or not, I get kids on BOSU as soon as I can. Just the act of trying to support themselves, even if it's just a neutral stance, nothing fancy initially, they activate lots of muscle groups, including their trunk and including whatever you need to do to be activated down below. So I typically would start in a sitting position with maybe a bench or a table just at the height where they can transition forward and stand on the BOSU with me supporting it if need be. And in quite short order, as they're able to, they're doing squats, they're doing weight shifts on there, they're doing just stable standing with me having them throw or catch some sort of basketball or just reach out in different positions. So don't think that these kids can't be put onto these pieces of equipment and do their work. Two other things that I find are very helpful, the knee glide on the upper left. My typical hack for the knee glide, piece of slick maybe towel or cloth on the floor, and you're sliding that back and forth. This is specifically made for this activity, and it's portable. You can take it with you if you're a home therapist who goes back and forth. If you're in a facility, it's a good piece of equipment to purchase, just to have as another I jump to your therapy. Lastly, or on the bottom there, we have an agility ladder. It's not only for training football players. Our patients sometimes do well with some sort of targeting system. So if it's one spot you're having them step to, that's fine. If it's consecutive activities you're doing and you're really giving them that space that the agility ladder presents and an obstacle to step over, it's really a good way to, in different ways, address gait activities, pre-gait activities, whether it's weight shifting, and getting good step length when you're not always there to point to a child or physically manipulate them. It gives them some independence when you're maybe supporting their trunk, but not putting their feet from spot one to point A to point B. Next slide, please. If there are any questions, I'll try to address them on, wow, 44 questions in there. I know they're not all for me.
Dean, thank you very much. That was a thorough and very clear talk about the postoperative physical therapy for our patients.